Hi everyone, welcome to our module on white blood cell disorders. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that is on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. Now let's start from absolute basics. White blood cell disorders are broadly divided into two groups, leukemias and lymphomas. Leukemias are cancers that originate in the bone marrow, that the place where the blood cells are produced, because they arise in the marrow and the abnormal cells easily spill into the bloodstream. They enter uh, they can easily spill into the bloodstream. That's why we call leukemias as a liquid tumor. Lymphomas, on the other hand, are those that arise from the lymphoid tissues like lymph nodes, spleen, thymus. Instead of circulating freely, they form solid tumor masses. So the simplest way to remember this is leukemia is nothing but a circulating cancer, whereas lymphomas are solid tumors in lymphoid tissues. Now, within leukemias, we classify them into acute and chronic. This classification is based on how mature the cancer cells are. In acute leukemia, the cancer cells are very immature. These immature cells are called as blasts. They divide rapidly, but they don't function properly because they grow so fast. The disease progresses quickly and becomes life-threatening if not treated early. Whereas chronic leukemias, the cells are more mature. They may still function partially and they grow more slowly. So patients may remain asymptomatic for a long time. So always we can remember this using uh, we can remember that acute may be immature and aggressive, whereas chronic may be mature and slow. For diagnosis, we use a very important cutoff. So if more than 20% of the cells in the bone marrow are blasts, we call it as acute leukemia. Now let's question ourselves. Why do patients become sick in those patients with acute leukemia? It's because the bone marrow gets crowded with these cancer cells. Normally, the bone marrow produces red blood cells, white blood cells, and platelets. But when these blasts take over, or more than 20% of the cells in the bone marrow are blasts, what happens is the red blood cells disappeared, leading to anemia, which presents with fatigue and pallor, whereas platelets decrease, leading to bleeding and bruising, and normal white cells decrease, leading to recurrent infections. So the symptoms are actually due to bone marrow failure. Now let's talk about acute lymphoblastic leukemia, commonly called as ALL. This is the most common leukemia that is seen in children. It also arises from immature lymphoid cells. Uh, One very important marker here is an enzyme called as terminal deoxynucleotide transferase, TDT, terminal deoxynucleotide transferase. So this enzyme is present only in immature lymphocytes. So whenever you see this marker, think this is an immature lymphoid cell, therefore it should be possibly an ALL. Now, ALL is divided into two types based on the type of lymphocyte involved. In B cell ALL, the cells express markers like CD10, CD19, and CD20. These are proteins that are present on the B cells. There are also important genetic changes. For example, translocation between chromosomes 12 and 21 is associated with a good prognosis. But if you see a translocation between chromosomes 9 and 22, that could indicate a poor prognosis. Now, T cell ALL is different. So it typically occurs in teenage boys and presents as a mass in the chest. So why is the chest mentioned with T cell ALL? Why is it commonly affected? because the T cells generally mature in the thymus, which is a lymphoid tissue, and this thymus is located in the mediastinum. So when these cells become cancerous, they form a mass at the mediastinum or in this region. Now we move to acute myeloid leukemia or AML. So this is more common in adults, especially older adults. It arises from the myeloid precursor cells, the cells that normally give rise to the neutrophils, monocytes, and other non-lymphoid cells. So one key feature that helps us identify AML is the presence of an enzyme called myeloperoxidase, MPO. This enzyme is found in myeloid cells, so it helps us distinguish between AML from ALL. A very classic and important finding in AML is something that's called as Auer rods. These are needle-shaped structures that are seen inside the cytoplasm of these characteristic abnormal cells. They are usually made up of granules from the cell. So if you ever see a microscopic image with these rod-like structures, you should immediately think of acute myeloid leukemia. Clinically, the symptoms again come from the bone marrow failure, presenting with anemia, which could present with fatigue and reduced WBCs, can present with infections, and thrombocytopenia, present with bleeding. Now let's focus on a very important subtype of AML called acute promyelocytic leukemia. This condition is caused by a translocation between chromosomes T15 and 17. This affects a receptor that is involved in cell differentiation. Normally, immature cells mature step by step into functional cells. But in this condition, what happens is the maturation process gets blocked because of RAR alpha fusion. So the cells get stuck in an immature stage and they just accumulate. There's accumulation of characteristic promyelocytes. This condition is extremely important because it has a serious complication. These abnormal cells release substances that activate clotting. So this leads to dangerous condition where the body forms clots everywhere and then starts bleeding. So this is nothing but disseminated intravascular coagulation. No, that's the interesting part. Instead of killing the cancer cells directly, we use a drug that forces them to mature. So once they mature, they stop behaving like cancer cells. So that's the reason we use all trans retinoic acid, also abbreviated as ATRA. And the mechanism of action of all trans retinoic acid is that it forces distribution of blasts and helps them mature so that they don't behave like cancer cells. When the cancer cells die rapidly, especially after starting treatment, they tend to release their contents into the bloodstream. So when this happens, it can cause several changes. Uric acid increases because DNA is broken down. Potassium increases because it leaks from the cells. Phosphate increases and calcium decreases because this calcium binds the phosphate that's released. So these changes can damage the kidneys, increase the potassium and increase uric acid. These changes can just damage the kidneys and they can cause life-threatening complications. So this is something we must always anticipate whenever there are cases of aggressive cancers. Now we move to chronic leukemias. Chronic myeloid leukemia involves overproduction of mature myeloid cells. So one key clue is an increase in basophils, a type of white blood cells. So if you see basophilia, you should always think of this condition CML. So this CML involves overproduction of mature myeloid cells, especially basophils. The hallmark of this disease is a genetic abnormality called as the Philadelphia chromosome. So this results from a translocation between chromosomes T922. This creates a fusion protein that acts as a that acts as a constant activating signal for cell growth. and that fusion protein is nothing but BCR-ABL gene. It's like a switch that's permanently turned on, so the cells keep multiplying without any kind of control. So the mechanism of action of this BCR-ABL gene is that it constitutively activates the tyrosine kinase, and this leads to uncontrolled cell proliferation. Patients usually have a very high white blood cell count and an enlarged spleen. A very useful lab test is the leukocyte alkaline phosphatase. In this disease, CML, there is a low leukocyte alkaline phosphatase, and this helps it differentiate from infections where the score is generally high. Treatment involves targeting the abnormal protein directly. So we use a drug that blocks the activity of this protein. So this is an example of targeted therapy. So treatment involves the imatinib, which is a tyrosine kinase inhibitor, and if untreated, the condition of CML can suddenly transform into an aggressive leukemia called as the blast crisis. Chronic lymphocytic leukemia is the most common leukemia in adults. It involves mature B cells. On a peripheral smear, the cells appear fragile and break apart very easily, creating what we call as the smudge cells. These patients often have weak immune system because the abnormal B cells don't produce effective antibodies. So they're prone to recurrent infections, and they could also present with autoimmune hemolytic anemia. Now, shifting to lymphomas, they are nothing but the cancers that form solid masses in lymphoid tissues. They are divided into Hodgkin's lymphoma and non-Hodgkin's lymphoma. The hallmark of Hodgkin's lymphoma is the presence of Reed-Sternberg cells. They are large abnormal cells with a characteristic appearance that looks like owl eyes. They express specific markers CD15 and CD30, which helps us identify them. These cells originate from B lymphocytes. There are different subtypes of Hodgkin's lymphoma. One type is common in young females and often involves the chest. Another type is associated with Epstein-Barr virus infection. Another is seen in immunocompromised individuals like those with HIV. So, nodular sclerosis is seen in young females, and often there's mediastinal involvement, and this nodular sclerosis is also the most common subtype of Hodgkin's lymphoma. Mixed cellularity is associated with Epstein-Barr virus infection, and lymphocyte depleted is seen in those patients who are immunocompromised, like those patients suffering with HIV and elderly patients. Now let's try to differentiate between Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma spreads in an orderly fashion from one lymph node to the another, so it is contiguous in nature of the spread. Whereas non-Hodgkin lymphoma spreads randomly and often involves organs outside the lymph nodes. It spreads through a non-contiguous way. Also, Reed-Sternberg cells are present in Hodgkin's lymphoma only and are absent in non-Hodgkin's lymphoma. Extranodal involvement is rare in Hodgkin's lymphoma, and extranodal involvement is common in non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma are a diverse group of cancers, so they can arise from different types of lymphocytes and can behave very differently. They often involve areas outside the lymph nodes. They often involve extranodal sites, as already discussed, like the gastrointestinal tract or the skin. And there are no Reed-Sternberg cells in non-Hodgkin lymphoma. Each type of non-Hodgkin lymphoma has a characteristic genetic change. So, one type has a gene that increases cell growth, another has something that prevents cell death, and another just has something that increases cell cycle progression. So, these genetic changes explain why the cells grow uncontrollably. Burkitt's lymphoma is due to translocation at 8 and 14 leading to mutation of CMYC. The characteristic appearance of a peripheral smear in Burkitt lymphoma is starry sky appearance, and it also presents with a jaw tumor or abdominal mass in those patients coming from endemic regions. Follicular lymphoma is associated with T1418 translocation, and this leads to mutation of the BCL2 gene. So BCL2 is nothing but a tumor suppressor gene, and because BCL2 is mutated, it inhibits apoptosis, and this presents with indolent, painless lymphadenopathy. Whereas coming to the other subtype of non-Hodgkin lymphoma, the mantle cell lymphoma, it is due to 1114 translocation and leads to a mutation in cyclin D1. Cyclin D1, as we all know, it's a cell cycle division checkpoint. It regulates a cell cycle division checkpoint, and mutation of the cyclin D1 could lead to increased cell cycle progression. And this presents uh, the characteristic peripheral smear presents with an expanded mantle zone and bone marrow biopsy also looks like an uh, sorry, the lymph node, whenever under histopathology or microscopy, there's expanded mantle zone. The other subtype is diffuse large B cell lymphoma. So in this, and this DLBCL is the most common non-Hodgkin's lymphoma. This is generally aggressive, but it's also curable. And the other one is adult T cell lymphoma, which is associated with HTLV1 infection and presents with characteristic skin lesions. And there are also features of hypercalcemia. And on peripheral smear, there are characteristic clover leaf cells that looks like what's shown on the image. So if you So before ending the video, I would like to quickly summarize the entire all the concepts that are discussed in this module. So we can just focus on these patterns if we feel overwhelmed. So whenever there's immature lymphoid cells, we have to think about a possibility of ALL that presents with greater than 20% blast cells. Whenever there are myeloid cells with rods, we can think about uh, AML, hard rods, those rod-like azerophilic granules. Whenever you see that characteristic appearance on a peripheral smear, you can think about AML. Whenever there's specific translocation, T1517 translocation along with clotting mentioned in a question, along with DIC mentioned in a question, we can think about APL. Whenever there are large number of white blood cells with a specific chromosome of BCR-ABL mutated gene due to a translocation of T922 and also with a low LAP, you can think about CML. Whenever there's fragile lymphocytes, which leads to characteristic smudge cells on peripheral smear, we can think about CLL. Whenever there's owl eye appearance on cells that are characteristically called as the Reed-Sternbach cells, we can think about Hodgkin lymphoma, and Hodgkin's lymphoma is associated with CD15, CD13 mutation. And the last two things to discuss are the Burkitt's lymphoma, which has a characteristic starry sky appearance on peripheral smear, sorry, on lymph node biopsy. And the characteristic translocation is 814. Follicular lymphoma is due to BCL2 mutation because of a characteristic translocation T1418. I hope this video helped you. Stay tuned for the next video. Thank you so much. Bye.